experience a dysphagia due to an iron deficiency. One of the findings associated with this dysphagia, as you can imagine, is going to be a microcytic hypochromatic anemia. And so, some people with iron deficiency, they just present with this anemia, characterized by small RBCs that are rather pale looking. Other individuals will go on to develop other features of iron deficiency, including a whole spectrum of findings we collectively refer to as Plummer-Vinson syndrome. Now, Plummer-Vinson syndrome is actually characterized by many things, but one of the most prominent features of Plummer-Vinson syndrome, in addition to the iron deficiency anemia, is the development of dysphagia due to esophageal webs. Esophageal webs are these very large folds in the wall of the esophagus. They're actually folds in the esophagus's submucosa. And these folds kind of stick out, they protrude, and partly obstruct the lumen of the esophagus. And so when people try to swallow, these folds are in the way, and they cause some degree of dysphagia. Let's take a look at these esophageal varices. So these are the esophageal webs of Plummer-Vinson syndrome. So again, here's an endoscopy. You're looking at the lumen of the esophagus. You notice again, it's a healthy white color, lots of vasculature that you can see here. There's the rest of the lumen of the esophagus. Everything would be normal except for this. This shouldn't be here. We'll do it highlight. Everything should be here except this. That is what we call an esophageal web. It's a fold in the submucosa of the esophagus. It's not really clear why these webs develop in association with iron deficiency. Whatever be the cause, they stick out in the lumen. And as they stick out in the lumen, you can see how they're going to impede peristalsis. And people will experience dysphagia. Now, there's some other findings associated with Plummer-Vinson syndrome. In addition to these webs, they might have other features that you can easily discover on physical exam. Some of the other features that may or may not accompany Plummer-Vinson syndrome include appendicitis as well as angular stomatitis. Let's take a look. Here's some additional findings of Plummer-Vinson syndrome. One of the other findings of Plummer-Vinson syndrome is this kind of swollen, smooth tongue. This is called atrophic glossitis. Glossitis just being an inflammation of the tongue. The atrophic refers to the lack of topography that you typically have on the tongue. Normally the tongue is remarkable for papillae, crevices. There's a variable topography of the lung. It's very kind of a rough surface. This tongue has a very smooth surface. It lacks the features of a normal tongue. And this is parents refer to as atrophic. So the inflammation of the tongue is referred to as an atrophic inflammation or an atrophic glossitis. Something you may see in addition to all the other features of Plummer-Vinson syndrome. Another feature of Plummer-Vinson syndrome is an inflammation of the angles of the mouth. This is called an angular stomatitis. It's just that inflammation. Sometimes the angles of the mouth will also ulcerate. You'll see linear ulcers. That also is a feature that you may see in Plummer-Vinson syndrome. Okay. You also might see to some degree inflammation of the gums mucosa. That's called an angular cheilitis. So you got a stomatitis, inflammation in the corners of the mouth, and inflammation of the mucosa and gums, and it's a cheilitis. Again, these are additional features you can see with Plummer-Vinson syndrome in association with an iron deficiency anemia. Okay. The whole syndrome name could be called Plummer-Vinson syndrome, or it may be just referred to as sideropenic dysphagia. Okay, let's talk about presentation again. Iron deficiency pretty much a given. If someone has that degree of iron deficiency, they're going to have a microcytic hypochromatic anemia. The question is whether they present with all these other features or not. They'll have general weakness. Again, the esophageal webs would probably be one of the more prominent features of Plummer-Vinson syndrome. That may or may not be accompanied by the atrophic myositis and stomatitis. So the workup, someone's going to present with dysphagia. You may or may not know that they have an iron deficiency anemia. But anyone that generally presents with dysphagia is going to get an upper GI series. And the reason for that is we have to discover the cause of the dysphagia. Is it functional or is it mechanical? If it's mechanical, we want to rule out a tumor, particularly some sort of esophageal cancer. If the person has esophageal cancer, the earlier we detect it, the better. We don't want to miss something like that. The esophageal cancers all have very poor prognoses to begin with. So the earlier we can detect it, the better off we are. So anyone that presents with a dysphagia should have a workup like that. Well, this, of course, this dysphagia, this Plummer-Vinson syndrome, is mechanical in nature. It's not caused by a tumor mass. It's going to be caused by these esophageal webs that you'll see on an upper GI series. Okay. Also, when you see stuff like that, you start putting things together. Oh, maybe this person has Plummer-Vinson syndrome. You see the esophageal webs. We get the history of being tired. The person might even look pale. You're going to get a CBC, complete blood count. Of course, you're going to discover that there are some irregularities. Okay, you find the person has a hypochromatic microcytic anemia. Once you establish the association of dysphagia to an iron deficiency, you're going to start thinking this is Plummer-Vinson syndrome, particularly if there's other features like angular stomatitis and atrophic glossitis. So eventually you're going to want to get a biopsy of the esophageal mucosa. If it is indeed Plummer-Vinson syndrome, then you'll see some evidence of inflammation, and more disconcerting, you might see some evidence of dysplasia, which is a forerunner of cancer. Okay, and then you'll have to address that. The way that you deal with this condition is you supplement the person with iron, usually in the form of ferrous sulfate. Okay. Any questions on this? Bless you. Okay. All right, let's talk about esophageal cancers. Just in general, esophageal cancers have a miserable prognosis. The reason, usually, they're discovered late. They've discovered often after they've metastasized. And that's because the symptomatology really doesn't present until very late in the development of the cancer. Let's talk about some general presenting features of esophageal cancers. You have some sort of mass growing in the esophagus. The person is first going to start to complain because there is a mechanical obstruction developing in the esophagus. And usually that complaint will take the form of dysphagia in response to trying to swallow solid foods. As the mass grows in the esophagus, the lumen is going to become stenotic. The more stenotic it becomes, the more difficult it will be for the person to swallow solids. Eventually, a point comes where the person not only is having dysphagia to solid foods, but they have dysphagia to liquids as well. It's much easier for a liquid to traverse a stenotic esophagus. And so the stenosis has to be pretty advanced in order for someone to complain about dysphagia trying to swallow liquids. Once a person is dysphagia swallowing liquids, that mass must be significantly obstructing the esophagus. Typically, these symptoms will develop over a period of months. And that's consistent with the typical growth of cancers in the esophagus. It takes them months to grow. And so the progression will be relayed to you over the course of the last several months. Maybe this whole thing started 6 months ago, and now it's becoming unbearable. I can't even drink liquids without feeling the sensation of dysphagia. That's probably the history that you're going to get. All right, let's talk about some of the different types of cancers. Two primary types of cancers you see: squamous cell carcinoma of the esophagus and adenocarcinoma of the esophagus. The locations in which these cancers develop, the antecedent conditions of these cancers are different. If you remember the locations of these types of cancers, where they develop in the esophagus, and their associated antecedent conditions, you can make a pretty good guess what type of esophageal cancer a person has, just based on the history and location the cancer is developing in the esophagus. Let's take a look. Squamous cell carcinoma, important things to remember. Antecedent conditions: drinking and smoking. Drinking and smoking, those are the most common antecedent conditions for a person to develop squamous cell carcinoma. Location, proximal 2/3 of the esophagus. So if you have a person who's got a history of drinking and smoking, and there's a mass in the proximal 2/3 of the esophagus, your bet's going to be on squamous cell carcinoma. The second type of cancer that develops in the esophagus is called adenocarcinoma. It's just a generic name for cancer that develops from glandular tissue. This type of cancer has only one known antecedent condition, and that's GERDs causing Barrett's esophagus. Typically develops in the distal 1/3 of the esophagus. So if you have a person with a history of GERDs and a mass that's developing in the distal 1/3 of the esophagus, your bet is going to be on adenocarcinoma. Okay, those are some of the important things you should remember. Will help you making the diagnosis of various types of cancers of the esophagus. So let's take a look first at squamous cell carcinoma. Again, important things: drinking and smoking. Those are the most common antecedent conditions. There are some other things that can cause squamous cell carcinoma of the esophagus. For example, the esophagus is infected with an oncogenic serotype of HPV. Sometimes that can occur as a result of receptive oral intercourse. If there's semen that's contaminated with HPV, gets in the throat, it can colonize the esophagus. Typically, when a squamous cell carcinoma develops in the esophagus, it's going to develop somewhere in the proximal 2/3 of the esophagus. All right, let's have a look at this squamous cell carcinoma of the esophagus. Here's an example of a squamous cell carcinoma developing in the esophagus. The morphology of the mass can be variable. Sometimes it's a pretty bulky exophytic mass. Sometimes it will present as what we call an ulcerative mass. Here's an example of a squamous cell carcinoma assuming an ulcerative mass. We have a resection of part of the esophagus affected by cancer. The specimen again has been opened, so now you're looking down at the mucosal surface. That is the mucosal surface. You're looking right at the epithelium of the mucosal surface, and again you can see it's this white color. Right there is a normal epithelium consisting of stratified squamous cells. That's a normal mucosa. However, you look over here, you can see this mass. There's the whole mass right here. And you'll notice the mass consists of this growth with kind of very heaped up margins. These margins are not coplanar with the rest of the mucosa. And in the center, you kind of got this deep ulcer. That's one of the typical morphologies for squamous cell carcinoma of the esophagus. Heaped up margins with a centralized ulcer. That's what we call a mass with ulcerative morphology. Classic for squamous cell carcinoma. Okay, let's have a look at this cancer. We're going to take a section right there. So here is a section through the mucosa of the esophagus in the area of that mass. So here's the lumen of the esophagus right here. Okay, and you can see the wall of the esophagus over here. Over here looks like a fairly normal wall. Okay, it looks like we have the mucosa here. There's the epithelium. It's a normal stratified squamous epithelium. This, of course, is the lamina propria. And this little layer of smooth muscle, that's the muscular mucosa. So 1, 2, 3, those are the 3 layers of the mucosa. Everything looks good here. Below that, you have the submucosa. Okay, that looks good too. Everything looks good over here. Nice, normal looking wall. Over this way, towards the mass, you can see where there's an area of the epithelium that's disrupted. You have normal stratified squamous epithelium suddenly turning into an area where the epithelium is disrupted. Instead of a normal epithelium, you see these atypical squamous cells, many of which are making little tumor islands. Okay, this is the cancer. The cancer is eating its way through the wall of the esophagus, disrupting the epithelium, disrupting the mucosa, and it's actually right down here into the submucosa. Over here, the wall's been even eroded even more. You can see here, this disruption is going right past where the muscularis mucosa should be. That's a deep defect. We call it ulceration. And so you have this cancer that has ulcerative morphology. Cancer is eating right through the wall of the esophagus, creating a central ulcer. And this is one of the morphologies that can be assumed by a squamous cell carcinoma of the esophagus. Let's have a look at this mass. Okay, here's an example of a squamous cell carcinoma growing in the esophagus. You'd expect this type of cancer to grow into the proximal 2/3 of the esophagus. In history, probably be drinking and smoking. Okay, you're looking at an upper GI series of a person's esophagus with squamous cell carcinoma. The proximal esophagus up here looks pretty normal. Okay, it's filling nicely with barium. Distalmost portion of the esophagus looks okay. It's filling uniformly with barium, but in between you can see this area over here, which the lumen looks really strictured. Also, you notice the normal esophagus has a smooth topography. Whatever this is, it has a really rough, jagged topography. This is where the cancer is growing. It's growing and extending into the lumen, causing the area to become stenotic. And this rough surface you see is actually the surface of the cancer. Now, if you look carefully, you can actually see the extent of the mass and its growth. You can actually see the shadow of the mass. So there's the mass. It's growing around the lumen of the esophagus in annular distribution. Annular meaning around the esophagus. It's growing inward and it's causing this area of stenosis to develop. Now, someone who's got that area of stenosis is going to complain of dysphagia. And they're going to complain of progressive dysphagia as this mass grows. So first off, they'll start to feel something kind of odd when they're swallowing solid foods. Okay? Large chunks of meat especially tend to get stuck here, and they'll experience dysphagia. But the dysphagia won't stop. It'll be progressive. As more time goes on, they'll complain of more and more dysphagia until finally they can't even drink liquids without feeling the dysphagia. And usually the progression will be over months, probably a 6-month or more period. By the time they present to the doctor, this lesion is usually pretty advanced. There are more, when a cancer like this is growing in the esophagus, not only does it tend to present late, but very early on, a cancer like this will metastasize because the esophagus itself is rich in lymphatics. And it doesn't take much for a cancer like this to get into the lymphatic system and disseminate. So you've got a couple of problems working against the patient. One, it doesn't present really until late with a lot of different symptoms. And two, you tend to have early metastatic spread because of the rich lymphatic system of the esophagus. So those two things really work against the patient. And as a result, by the time the patient presents, usually this cancer not only advanced, but it's in an advanced stage. And as a result, the survival rate of esophageal cancers are pretty miserable. 5-year survival rate is only about 20%. So 4 out of 5 people are going to be dead within 5 years of being diagnosed with esophageal cancer. Now, when you discover these things that have already metastasized, there's really a local excision is not going to be curative. You would have to have some sort of combination, maybe radiation, chemotherapy, to try to get the cancer under control. It usually isn't very successful because of the advanced stage of the cancer. However, this condition makes it almost impossible for a person to eat. And so if we don't do something about this obstruction, the person's just going to starve to death. So we do perform a local excision. But the local excision is not curative, it's palliative. We cut out this part of the esophagus. Okay, it's an esophageal resection. Now when you cut out part of the esophagus, the ends won't come together. The esophagus is too short. So how do you anastomose the two ends? Basically what you have to do is you have to go down, open up the esophageal hiatus and pull the stomach through. Put it in the thoracic cavity and then reconnect the esophagus. This whole procedure is called an esophageal resection with pull through. And that's the only way you can connect the ends of the esophagus. So after this procedure, the person has the obstruction relieved, but their stomach is in the thoracic cavity. And so they have to be careful with a few things. They can eat, at least, but they have to eat smaller quantities frequently. If they eat large meals, that will cause a compression atelectasis of the lungs. Okay, any questions on this? All right, so let's just review a couple of generalities, and then I want to point out a few exceptions. Some generalities you should remember for squamous cell carcinoma. Again, drinking, smoking, proximal 2/3 of the esophagus. Cancerous mass under those conditions, you'd guess would be squamous cell carcinoma. But there's one notable exception to this. Achalasia. You remember achalasia is a condition where the LES clamps down hard and won't let food pass into the distal, from the distal esophagus into the proximal stomach. Some people with achalasia will develop a squamous cell carcinoma because of the inflammation that's persistently caused by the stagnant food. When that cancer develops, it's often a squamous cell carcinoma. The exception there is that type of squamous cell carcinoma caused by achalasia develops in the distal 1/3 of the esophagus. So it's kind of the exception of the generality. Remember, board authors like to ask about exceptions. That's an exception. That's a notable exception. Any questions on squamous cell carcinoma? Okay. Second type of cancer we see is adenocarcinoma of the esophagus. Now, adenocarcinoma has one proximal antecedent condition, and that is GERDs. A lot of things cause GERDs, but the most proximal condition causing adenocarcinoma of the esophagus is GERDs. Generally, the sequence of events is someone develops GERDs. They develop Barrett's esophagus, that metaplastic change. And then that metaplastic change degenerates into dysplasia in some, and from there, people can develop an adenocarcinoma. Let's take a look at this. Okay, adenocarcinoma of the esophagus. This is typically the way it develops. Again, we have a normal epithelium here investing the distal esophagus. It's a stratified squamous epithelium. Okay. Because of reflux disease, this epithelium is damaged. The body wants to invest the esophagus with a more protective type of epithelium. That happens to be a mucus-secreting columnar epithelium. That is the metaplastic epithelium. Okay? It's a mucus-secreting columnar epithelium. We call it Barrett's esophagus. It presents with this mucilaginous, velvety red area in the distal esophagus. For most of us, that's where the problem stops. However, a subset of these individuals go on to develop dysplasia in this area. This dysplastic epithelium will evolve into a carcinoma in situ. You know that's the immediate form of cancer. Eventually, some of these cells can break through. They can break through the basement membrane that normally keeps them confined to the epithelium. Once they break through that basement membrane, we call that local invasion. And at that point, that is no longer dysplastic, that's a locally invasive cancer. The cancer is making glands. Okay? And as a result, we call that an adenocarcinoma. Okay, so let's go through some general features of these esophageal cancers, both squamous cell and adenocarcinomas. General presentation, again, dysphagia. It's a progressive form of dysphagia. Squamous cell carcinoma, adenocarcinoma, those will both present with progressive dysphagia. Again, usually you're looking at a timeline over 6 months or more. There'll be some weight loss. That weight loss is the result of 2 major factors. Number 1, it hurts when they eat. They don't like that feeling of dysphagia. And secondly, as they develop more advanced cancer, they develop that phenomenon called cachexia. That's that emaciating syndrome associated with advanced cancer. They also might experience dinophagia, pain with swallowing. Okay, the workup, again, they'll tell you that they have dysphagia, so they're not going to know what this is at first. You're going to want to determine whether this is a functional problem with peristalsis or this is a mechanical problem. So your most likely first imaging study is going to be an upper GI series. And of course, you're going to see some strictured area on the esophagus on an upper GI series. You'll follow that up with an endoscopy. You'll biopsy the mass to confirm that it's a cancer. And again, just by location and antecedent conditions, you're going to guess what kind of cancer this is. You're going to follow that up with some staging procedures, maybe a CT scan. CT scan will be mostly focused on the local lymph nodes. You're going to see if there's likely cancer in some of the local lymph nodes. That's part of the staging procedures to see how widely disseminated the cancer is. Unfortunately, in most cases of esophageal cancer, it's an advanced stage. Stage 3, stage 4. Okay, any questions on that? Okay, let's introduce you to some of the basics of gastritis, then we're going to call it a day. Next section, inflammation of the stomach. The gastritis. The word literally means just inflammation of the stomach. However, when clinicians use this term, gastritis, they don't really mean inflammation of the stomach. They really are referring to inflammation of the mucosa of the stomach. So what they really mean is a mucogastritis. But they don't usually say that. They say just gastritis. There are different forms of gastritis, both acute and chronic. Acute gastritis is really symptomatic. Someone has an acute inflammation of the mucosa of the stomach, a mucogastritis. They're pretty symptomatic. They're vomiting. Usually the acute inflammation results in some erosions of the stomach that cause hemorrhaging, so they're vomiting up some blood. It'll be in the form of pink-colored fluid, not whole blood. They just generally feel lousy when they have acute gastritis. Okay, very symptomatic. chronic gastritis, usually it's relatively asymptomatic. It's kind of an indolent process. Chronic gastritis, however, does have some long-term consequences. Chronic gastritis can cause a condition called gastric atrophy. Gastric atrophy means that the stomach is no longer capable of producing gastric juices. No acid, no digestive enzymes. And that's because the chronic gastritis causes a metaplastic change in the gastric mucosa. And I will show you that. The metaplastic epithelium can't produce acid, nor can it produce enzymes. In addition, the chronic gastritis can cause dysplasias, which results in gastric cancers. So, acute gastritis, very symptomatic. There usually aren't some terrible long-range consequences. It's very inconvenient to have at the time, though, because you're vomiting up a lot of pink-colored fluid. You feel lousy. Probably in a lot of epigastric discomfort. Chronic gastritis is indolent. It's almost asymptomatic, but it does have some long-term consequences. Gastric atrophy, which describes the metaplastic transformation of the epithelium, making the stomach incapable of making gastric juices. That's why we call it atrophy. Possibly dysplasia and gastric cancer. Okay, let's just talk about gastric atrophy and we'll call it a day. We're going to first discuss chronic gastritis. Chronic inflammation of the gastric mucosa. Caused by lots of things, but right on top of the list is an infectious agent called Helicobacter pylori. Let's talk again, just in general, about the features of chronic gastritis. Let's first take a look at normal gastric mucosa. That's a section through the gastric mucosa. There's the lumen of the stomach. And we see part of the mucosa here. Okay. Included in the mucosa, of course, you've got this epithelium. This is what we call a secretory epithelium. The stomach produces secretions, so we just call it a secretory type of epithelium. You've seen this epithelium before in physiology. The epithelium is remarkable for these deep gastric pits. Within each pit, you have a number of different types of cells. The top of the pit, you generally see these mucus-producing cells. They produce secretions, mucus, that protects the lining of the stomach from its own acid. Midway down the gastric pit, you see these pale cells. Those are the parietal cells, responsible for producing hydrochloric acid and that glycoprotein you know is intrinsic factor. Helps you absorb vitamin B12. Deep down in the pit, you usually find these dark staining cells. Those are chief cells. They're responsible for producing pepsin and chymosin, a lot of the digestive enzymes in the stomach. This is an acid secretory producing epithelium. That's a normal epithelium. Something chronically inflames this epithelium. A metaplastic transformation occurs. This secretory epithelium turns into a mucus-producing columnar epithelium. Let's take a look. Here's an example of metaplastic gastric epithelium. A little lower power. You can see this is the mucosa down over here. This is the submucosa over here. You can see the muscularis propria or externa down here. They've got a nice thick section. Look at the mucosa. The mucosa here is no longer remarkable for gastric pits. Instead, what you see are these villi-like structures that are lined by mucus-producing columnar epithelial cells. No gastric pits, just villi with a lot of mucus-producing columnar epithelial cells. You'll also notice the lamina propria is remarkable for lots of inflammation. And down deeper, you can even see follicles of inflammatory cells. This is called follicular gastritis. It's a follicle of inflammatory cells. This is no longer an acid-producing type of epithelium. It just produces a lot of mucus. No acid, doesn't have any cells to produce acid, no parietal cells. Doesn't produce any enzymes, no parietal. There are no tube cells here to produce any kind of enzymes. All you're producing is a bunch of mucus. And as a result, we say that this epithelium is atrophic. This is called atrophic gastritis. It's an inflammation of the stomach that leads to atrophy of the mucosa of the stomach. All forms of chronic gastritis tend to cause atrophy of the gastric mucosa. We'll talk next time. The most common thing that causes inflammation of the mucosa of the stomach is Helicobacter pylori. That's a type of infectious gastritis. There's